You are welcome to my channel. I'll be talking about adenosine. Adenosine could be known as adenoscan, Adenoscan, or PMS adenosine. It belongs to the class of medications known as anti-arrhythmic agent and also a diagnostic agent. It will appear in various forms. In form of solution for intravenous administration, we can find that under the brand name Adenoscan at 3 mg per ml, or the brand name Adenoscan at 3 mg per ml or 6 mg per 2 ml. Also, adenosine generic at 3 mg per ml. Administration. We can use Adenoscan for rapid bolus intravenous use only. We can give this as IV push over 1 to 2 seconds. Let me reiterate that. Adenoscan for rapid bolus intravenous use only, given within 1 to 2 seconds. So you just have to give it very rapidly. You have to set the peripheral line close to the trunk. We don't want the peripheral line to be at the leg, lower arm, or the hand. And you can give 20 ml of normal saline instantly after you have given your intravenous Adenoscan push. Still on administration, you can use T-connector or stopcock or 2 IV lines. Use adenosine 6 mg plus 18 ml of normal saline IV push. If you are using central line, then please don't give the same dose as if you are using the peripheral line. In that case, the central line will have the dose decreased to half the dose of the peripheral line. Then, central line, you have to use 3 mg push. Still on administration, Adenoscan is for intravenous infusion and only through the peripheral line place. Uses. You can use adenosine to handle paroxysmal supraventricular tachycardia. But if you are dealing with that, first thing first, please, have Vagal maneuvers first. Then be sure there is no atrial fibrillation or atrial flutter. In the case of supraventricular tachycardia, that is AV nodal re-entrant tachycardia or AV re-entrant tachycardia, you can use adenosine. Still on uses, you can use Adenoscan for diagnostic purpose as a pharmacologic agent for stress test. In that case, Myocardial Perfusion with Thallium-201 scintigraphy could be in place. Monomorphic stable wide complex tachycardia could warrant the use of adenosine. And let me repeat, monomorphic, not polymorphic wide complex tachycardia. In other words, monomorphic ventricular tachycardia. You can use adenosine there. In narrow, complex, stable, regular tachycardia, you can use adenosine. In narrow, complex, unstable, regular tachycardia, you can use adenosine. Still on uses, in pulmonary artery hypertension, adenosine is used for the acute vasodilator testing. Adverse reactions: flushing, lightheadedness, dizziness, new arrhythmia after cardioversion. The affected person can now come down with atrial fibrillation or premature ventricular contractions. There might be chest pressure or chest discomfort. Also, can be dealing with headache, neck discomfort, dyspnea, AV block, chest pain, palpitations, diaphoresis. Also, there may be nausea, hyperventilation, asystole, blood vision, bradycardia, bronchospasm, or burning sensation. Still on adverse reactions, there could be hypertension, increased intracranial pressure, decreased level of consciousness, prolonged QT. Let me explain further on prolonged QT. With prolonged QT, that may become torsade point. If there's no correction, torsade point will degenerate to ventricular tachycardia, from monomorphic to polymorphic ventricular tachycardia, and then, if no correction, can degenerate to ventricular fibrillation, that is polymorphic ventricular tachycardia to ventricular fibrillation. If there is no defibrillation, then it can lead to asystole. Asystole without advanced cardiac life support instituted on time, then the individual will give up the ghost. So cardiac arrest and death. Contraindications. We cannot use adenosine if there's history of hypersensitivity to adenosine in the past in this individual, or if there's any sensitivity to any component of the formulation. Heart block. Heart block, second degree or third degree, either based on past history or EKG, you cannot use adenosine. SSS. Let me leave you to take a guess about what that is all about. You can? Okay, let me help. Sick sinus syndrome. There's a separate presentation on sick sinus syndrome right here on my channel. Please check that out. Okay, if that is the case, in this individual, please no adenosine today. Bradycardia. Well, bradycardia will not be a problem if there is pacemaker already in situ, pacemaker already inserted. Then you can go ahead with your adenosine today. No Adenoscan if there is bronchoconstriction or bronchospasm or severe lung disease. No Adenoscan, please. Warnings. We have to rule out Wolff-Parkinson-White syndrome in paroxysmal supraventricular tachycardia before we administer adenosine. And why that? The administration of adenosine is meant to help the patient, right? But it can actually teach anyone with Wolff-Parkinson-White syndrome to atrial fibrillation or atrial flutter. Adenoscan for stress test can result in stroke, myocardial infarction, or fatal cardiac arrest, and sometimes teach the patient to not sustain ventricular tachycardia. So we have to be sure that patient is not at risk of all this before we jab him or her with adenoscan for stress test. There may be production of first degree AV block. So be careful. When the heart rate is low and you've not run your EKG, you might not give that adenosine yet. So have the EKG done. Not in second degree or third degree heart block. Please no. Either based on past history or the EKG is revealing that right now. Once second degree or third degree heart block has been picked, then this candidate cannot take adenosine for anything. Still on warnings, we have to look out for signs of hypersensitivity reaction, like rashes, flushing, and so on. That is after you have administered the adenoscan. With Adenoscan, watch out for increased blood pressure because the patient might come down with hypertension. There might be severe hypertension with bolus dose while treating supraventricular tachycardia. So the cardiac monitoring and vital signs machine should be on. Watch out for polymorphic ventricular tachycardia. As a matter of fact, in polymorphic ventricular tachycardia, if that is peaked already, don't administer adenosine, please. Still on warnings, watch out for seizures that may be new or recurring in an individual with underlying seizure disorder. We don't give adenosine in any irregular tachycardia like atrial fibrillation or any form of irregular tachycardia like polymorphic ventricular tachycardia. Please no adenosine. Like I've just said, not in polymorphic wide complex tachycardia. And with that, it can lead to ventricular fibrillation. In anyone with low potassium and low magnesium, we will not give adenosine because anyone with these electrolytes at lower range can have prolonged QT. And on top of that, you are administering adenosine, then the probability of having prolonged QT degenerating to torsade point, to ventricular tachycardia, polymorphic ventricular tachycardia, ventricular fibrillation, asystole, now cardiac arrest and death is more. Still on warning, we are not going to use adenosine in heart failure and not very comfortable to use it in asthmatic patient unless we put certain things ahead of it. And with that, this medication might treat anyone into bronchoconstriction or bronchospasm. And in chronic obstructive pulmonary disease, we have to use it very cautiously. In any patient who had received heart transplant, there may be prolonged asystole. Drug-drug interaction. Diminish what? Caffeine can diminish the effect of adenosine. Leads to what? Carbamazepine and digoxin can lead to worsening of the side effects. Increase what? Nicotine can increase AV block. But in all this, contact your pharmacist or cardiologist because the list of medications that could interact with adenosine is pretty long and I cannot go over all of them right here. Contact your pharmacist or cardiologist, please. Rescue. How do I mean? This medication on its own is a rescue agent, right? From serious ventricular tachycardia and supraventricular tachycardia, right? But you need to get EKG now ready, and then get your resuscitation kit also ready. You can use medication to elicit atrial fibrillation or atrial flutter if the diagnosis is not very clear from the onset. Diet. Someone is asking me, what's the business with diet as per adenosine? Yes, I do. I have a business. No caffeine. In 12 hours before you administer adenosine, please. Mechanism of action. It slows down the conduction through AV node and also interrupts the re-entry pathway, thereby leading to no more sinus rhythm. It increases coronary vasodilation, but it cannot open any stenosis artery or arteries. That is the reason for the reduced Thallium-201 uptake in stenotic coronary arteries. Examples of situations where we can make use of adenosine are the following: paroxysmal supraventricular tachycardia You can give your adenosine at 6 mg intravenous push rapidly within 1 to 2 seconds. Give 12 mg bolus, and you can repeat the 12 mg bolus one more time. Then follow your push with 20 minutes of normal saline. The first dose can be reduced to half, that is 3 mg, if this patient is on carbamazepine or dipyridamole, or he or she has received heart transplant, or you are giving these adenosine through central line. Then reduce the dosage, please. Let me reiterate here. You have paroxysmal supraventricular tachycardia. You want to help the patient out correct. You want to use adenosine right. 6 mg IV push rapidly, 1 to 2 seconds. You are not winning? Give 12 mg IV push. Repeat that only one more time and you're done. When you push, follow with 20 minutes of normal setting. But if this is through central line, if this patient has taken carbamazepine or has taken dipyridamole or has received heart transplant, please cut the dose into half, please. Another example is sustained ventricular tachycardia. In that case, you can give 3 mg or 6 mg start. Then you can give 18 mg and repeat 12 mg after. And the last example would be cardiac stress test. Use peripheral line, a continuous IV line, give at 140 microgram per kilogram per minute for 6 minutes. Then, between that 6 minutes, at the middle, like the 3rd minute, inject your Thallium-201. Then, the result will tell you whether you are dealing with coronary artery that is open or stenosed. With that, I've come to the end of this very presentation. Adenosine is a very good medication to save many people in the face of supraventricular or monomorphic ventricular tachycardia. But there are so many situations when we cannot use adenosine. And we have to be very careful about the dosage and whether we're dealing with central line or not, whether this is in a patient with heart transplant or not, whether carbamazepine has been given before or not, whether dipyridamole has been taken or not, and of course, caffeine use also. Thanks for listening. Remember to subscribe to my channel. Remember to share this presentation. I appreciate it.